Good afternoon, everyone. Thank you very much, Dr. Badi, for that kind introduction. Uh, actually, I must thank you all first because your active participation matters most. That's what motivates us to do more lectures, actually. So, I think the time is now almost 12 noon. We'll start the lecture. I think others can join while we're doing the lecture. So, basically, I thought of doing this lecture because there's a common issue among our medical field. And nowadays, we see a lot of young generation coming with high lipid levels. So it's better to know the recent guidelines and the better way of management of this lipidemia, because I see many patients who's coming with non-STEMI, STEMI, strokes, TIAs, because the primary prevention part has been not done correctly. So if we do that part, we can, reduce the burden to our medical field if you do the primary prevention part better. So without further ado, we'll start the lecture. So basically, as usual, we'll start with the basics. So what are these lipids? So lipids actually plays a crucial role in our body from even before our birth, from pregnancy to death. It has a functional and structural components in our body. I don't have to explain. It's a part of our brain and it's part of our cell membrane, and it's an important chemical compound for absorption of vitamins, and it acts as an energy source as well. But this lipid has chemical characteristic that lipids are hydrophobic. So they need transport molecules. Those transport molecules are called lipoproteins. So I'll tell a bit about lipoproteins. Basically, lipoproteins are transport molecules which transfer these lipids. It has a hydrophobic core which contains triglycerides and cholesterol, and it has a hydrophilic shell which contains phospholipid, free cholesterol, and apolipoproteins. These apolipoproteins act as enzymes and ligands, and those are the structural components which gives each lipoprotein its characteristics. We'll discuss in further comment side as well. So with these lipoproteins, it categorizes based on density. That's what you get in your lipid profile. So we have chylomicrons and VLDL. It's a very low density lipoproteins, ideal intermediate density lipoproteins, low density lipoproteins, and high density lipoproteins. Free fatty acids come at the end. So this categorization occurs done basically depending on its density. So VLDL, IDL, and LDL has very low dense cholesterol compounds, but LDL, HDL has high dense cholesterol compounds. So I think that's the basic, physiological part of this lipid metabolism, the basic lipoprotein structure, and then how we categorize these lipoprotein structures depending on their density. It's not only about the density, that density characterizes its containing cholesterol levels. We can discuss it later as well in coming slides. So then about the lipid transport. So basically we have two ways of lipid transport, the exogenous pathway and the endogenous pathway. Exogenous pathway is from the intestine to the liver. It basically occurs to chylomicrons and chylomicron remnants. Those are basically clinically not that significant in our day-to-day practice. But this endogenous pathway is the pathway that is important to us. That's basically contain the transport of lipid from liver to peripheral tissues. It occurs to VLDL, IDL, LDL, and HDL. Basically, VLDL is the molecule which transfer lipid from liver to peripheral tissues. In midway, it convert to intermediate or the IDL, and then IDL convert to LDL. And this LDL is the one which cause deposition or the transport of bad cholesterol to our peripheries. That's the main lipoprotein molecule which cause the development of atherosclerotic disease. And the HDL, it's basically transport lipid from the peripheral tissues to our liver. So it acts as a good healthy cholesterol to reduce the atherosclerotic disease in peripheral vasculature. So that's the basic idea about the lipid pathophysiology for the basic physics. So then I want to highlight this factor. We all know about this lipid metabolism, lipoproteins, and how they transport. But in our setup, in our South Asian, our lipid metabolism is a bit different. So you can see this in this picture. In our South Asian region, uh, so these darker red areas indicate very high risk of development of atherosclerotic disease, and then the other areas, depending on their risk, the color is changing. In Sri Lanka, uh, it has moderate risk of development of atherosclerotic disease among our region. Compared to other regions like Australia, it's actually a low risk region. But compared to other regions of the world, we have high risk of development of atherosclerotic disease. Why is that? That's because we have atherogenic phenotype in our body. That means we have, compared to other regions, we have moderately elevated LDL cholesterol levels, which is the bad cholesterol. And we have comparatively low HDL cholesterol levels. That's a good cholesterol. And because of our diet, we have high triglycerides because we are taking diet which contain high carbohydrate, which convert to triglycerides. Because of this, we have high non-HDL cholesterol. Non-HDL means total cholesterol minus the LDL cholesterol, HDL cholesterol. Because all other cholesterol, including VLDL, IDL, LDL, all containing atherogenic cholesterol levels. So rather than LDL alone, non-HDL cholesterol is a better indicator of the risk of our development of atherogenic or atherosclerotic disease. So because of elevated LDL, triglycerides and all, we have elevated non-HDL cholesterol level. And other than that, there's an interesting part. Our LDL particles is bit different compared to Caucasians. Why is that? Our LDL molecules actually, the size of LDL molecules are much smaller than the Caucasian LDL molecule size. That's very important. Why is that? Because LDL is the molecule which go into the vascular intima and that causes atherogenic plaque formation. The lower the size, the higher the risk of development of atherogenic plaque. So because of our LDL molecules, the size is less than 70 nanometers, the risk is high. Even we have normal LDL compared to Caucasians, we have higher risk of development of atherosclerotic disease. And then the high ApoB particles and high lipoprotein A levels, I'll describe these two other particles in coming slides. So I think you can understand that we have atherogenic phenotype compared to other part of the world. So after that, after this background, I like to talk about the assessment of lipids, the lipid profile. So what we used to do is this fasting lipid profile, 8 to 12 hours fasting. That is the preferred way of assessing lipids. However, now non-fasting lipid profile also acceptable method of assessing lipid levels in our body. Because sometimes patient get admitted with MI, strokes and all. We are discharging patient with high dose statin, but we haven't checked and we never sometimes check his lipid levels. So in that kind of condition, you can direct away order a non-fasting lipid profile before discharge. What only thing is, in non-fasting lipid profile, if the patient has high triglycerides levels, usually triglycerides more than 400, in that kind of scenario, non-fasting is not accurate. Otherwise, you can use the non-fasting lipid profile to guide your lipid management therapy. I think you got that point. Because actually, in our lipid profiles, we get LDL from the calculation. We reduce the non-HDL cholesterol and from the total cholesterol, we reduce the VLDL and ILDL cholesterol from a calculator. From that, we get our LDL level. So LDL is not a basically measured value, it's a calculated one from our lipid profile. So when the patient has high triglyceride levels, the calculation is not, correct. So keep in mind, you can do fasting lipid profiles, provided that triglycerides is less than 400. If more than 400, you have to order fasting lipid profile for better accurate measurement of the lipids. Okay. The other interesting question, when to do the lipid profile. So we have few ways of doing lipid profile. One thing is general population screening. So actually, if adults age more than 40 years, guideline recommended to do lipid profile routinely every 4 to 6 years. That means if you are at your 40, you have to repeat your lipid profile at least 44 years of age. The guideline recommendation. But now the trend is screen early, treat early. That's the now coming trend. Then now the American guideline recommend starting lipid profile measurements from at least 2 years of age. This American recommendation is coming up with the newest guideline. However, in practical scenarios, in general population screening, if you age more than 40, at least once lipid profile should be done. And if the age is less than 40 years, still you can do lipid profile, provided patients having multiple risk factors. For instance, if the patient having primary lipid disorders, family history of hypercholesterolemia at the young, you can still do the lipid profile. And apart from this general population screening, you can do lipid profile in high-risk individuals. I think you all know the diabetic hypertension, CKD, other things. I want to highlight this fact, the patient with inflammatory disease. We usually don't do lipid profile in patients with rheumatoid arthritis, SLE or HIV. These chronic inflammatory conditions carries a high risk of development of atherosclerosis cardiovascular disease. So keep in mind, if patient having chronic inflammatory conditions, it's better to do lipid profile because most of the time they are having high elevated lipid profile. And of course, patient with established atherosclerosis cardiovascular disease, that means after stroke, after MI, and peripheral vascular disease, you should do a lipid profile. Those are the main three situations that you should do a lipid profile to assess his lipids. And this live protein A assessment. Have you ever heard of this live protein A? Okay, this again interesting field. So sometimes you may have seen patients coming with STEMI, strokes with fully normal lipid profile. Sometimes lipids are normal. LDL is almost below the normal. So why that happening? That because of this lipoprotein A molecule. It's actually a modified LDL particle. There's a lipoprotein A molecule. I'll show the picture. This is a normal LDL molecule. There's a lipoprotein called ApoB. In lipoprotein A molecule, this ApoB, there's ApoA. Again, kind of a protein attached to this lipoprotein ApoB molecule. So this variant of LDL particle, it carries the highest risk of development of atherosclerosis cardiovascular disease. It's actually independent factor of atherosclerosis cardiovascular. That means if your lipoprotein A levels is high, usually 50 nanogram per deciliter, that means there's a higher chance of development of MI or cardiovascular disease in near future. So this lipoprotein A, actually in our South Asian population, these lipoprotein A levels are much higher than compared to other Caucasians. Okay, so that's why the guideline recommended to assess this lipoprotein A. I don't know whether it's done in Sri Lanka, but better to have an idea regarding this lipoprotein A assay as well, because sometimes even if the patient comes with MI and all, if these lipid levels are normal, sometimes we tend to reduce the atorvastatin dose after MI. But we never know his lipoprotein A levels. Sometimes he might be having high elevated lipoprotein A levels. If without assessing that, it's very risky to reduce atorvastatin dose after MI or atherosclerosis cardiovascular disease. The actual guideline recommended to measure this lipoprotein A levels in premature. That means men less than 55 years and women less than 65 years of age who had a myocardial infarction or whatever the atherosclerosis cardiovascular disease. And significant family history of MI, strokes, and recurrent atherosclerosis cardiovascular disease despite normal LDL cholesterol levels. And suspected familial hypercholesterolemia, those kind of conditions, it's better to assess lipoprotein A levels, even though we don't have it in here. Actually, now the coming guideline, American guideline recommended to assess this lipoprotein A levels at least once in a lifetime. So I think, anyway, you can answer the question at any point if you have any doubts during my lecture. Okay. So this is the topic actually. This is the topic for the day, the management of dyslipidemia. I just told you about the basic background of about the dyslipidemia. So basically it has three parts. Always lifestyle modification come first, then the pharmacological management and the follow-up. A bit about lifestyle modification. I don't have to go through all the things because you all know better than me. It's recommended to go with physical activity at least 150 minutes. It's aerobic, moderate intensity activities, tight blood sugar control, healthy weight, but good lipids, higher control of blood pressure, not smoking, and adequate sleep, and healthy diet. That means guideline says dash diet or Mediterranean diet. Basically, the diet contains high vegetables and less amount of salt. So I'll skip this slide because our main area of interest is pharmacotherapy. So when to start the pharmacotherapy or drugs? That's actually, I think, this is okay. This slide actually explains full of my lecture. This is a summary of my lecture actually. So if you get a patient, we'll say you have a patient who has had previous MI or stroke or peripheral vascular disease. Are you going to start studying or not? Yeah, that means secondary prevention. If patient already had MI, myocardial infarction, stroke, there's no doubt you start studying. And if your patient having diabetes, age more than 40 years, are you going to start studying or not? You should start patient study. This is actually from our local guideline. I took this photo from our local guideline. So diabetic age more than 40 years, patient should be on statin. And CKD patient. Actually, CKD stage 3 and 5, 3 to 5. Those patients also should be on statin. Okay. But keep in mind, those patients should not be on hemodialysis. Okay. Non-hemodialysis CKD patient stage 3 to 5 should be on statin. Because hemodialysis patient, our biomechanisms are different. They develop atherosclerotic disease because of calcification, not because of lipid deposition itself. So their mechanisms are different. Guideline made for non-hemodialysis patient. And even if a patient having diabetic, age less than 40, or even type 2 or type 1, with other atherosclerosis cardiovascular risk factor. That means if you are a diabetic with the age of 35 who had a TIA, they also should be on statin, even the age is less than 40. And even your lipid profile, your LDL more than 180, that's again indication to start statin. Those are the indications to start statin straight away. Okay. So sometimes I haven't seen patients, even patients diabetic age 60, 50, they are not on statin. And CKD, it's very difficult to find a CKD patient get for on statin. Okay. And LDL 190. Usually LDL 190 they will start on statin anyway, but these are the patient population that should be on statin. Okay. And the other thing, if patient come with a lipid profile and the LDL is less than 190, then when do you start your statin? Okay. In that case, you need to assess the patient cardiovascular disease risk. The statin therapy depend on their future cardiovascular disease risk. Okay. I'll tell you how we are going to assess this cardiovascular risk. So basically, ultimately, patient will be categorized into three categories. They will be low risk, moderate risk, or very high risk. If patient future cardiovascular risk is coming as a low risk, usually they don't need any statin therapy. It's mainly the lifestyle modification and annual follow-up. If patient cardiovascular disease is moderate risk, usually we should review the patient within 3 to 6 months of time. And still their lipid target is not achieved, in that case, you can start moderate intensity statin. If patient risk is very high risk to very high risk, anyway, they should be started on statin. I'll tell how this risk stratification is being done. Okay, is anyone having any doubt about this statin initiation? Yeah. Yeah. Actually, sometimes you may see a patient with, we'll say, with 20 years of age patient come with a lipid profile LDS 200. In that case, what the guideline says, age doesn't matter. If the LDL more than 190 means they are having very high risk of development of atherosclerosis, cardiovascular disease. So you can straight away start. Problem occurs if the LDL is less than 190. Suppose the young patient comes with LDL of 180. I'll come that part in my later on my course. Definitely, even whatever the age, if the LDL is more than 190, you should start on statin. In pediatric age, there's a special things because hyperlipidemia can be due to raw reasons, can be due to secondary causes like diet, exercise, those things, and it can be due to primary disease as well. I'll discuss those part in later. The etiological wise, if your patient very young, you should evaluate for the primary causes of dyslipidemia. So the answer to your question, if the LDL is 190, usually it doesn't matter. You can straight away start statin, provided the other contraindications are not. Okay. So this risk assessment. Basically, it's like nowadays war, the Iran war. If you haven't assessed the risk of getting into this war, and you straight away starting fighting with each other, the outcome, the side effects, the outcome will be not, optimum. So basically, statin management depend on patient cardiovascular risk. Okay. So if patient already had a myocardial infarction or MI or stroke, so they are at higher risk, no doubt about that. You should start patient on statin. But patients haven't had any cardiovascular disease. In that case, your statin decision should be depend on patient risk. That's why you need risk assessment tool. Have anyone used these tools? WHO ISH tool, SCORE, Prevent AVSD. So there are actually few tools to assess these patients' cardiovascular risk. What our local guideline recommended is to use the WHO ISH tool. That means WHO International Society of Hypertension. That's the recommended risk assessment tool for our region. And this SCORE and SCORE 2 OP, that means this actually for the European population. SCORE 2 is for the 40 to 69 years of age. SCORE 2 OP means all the population more than 70. The Prevent ASVD is for the USA, the American population. I would prefer these two tools to assess the patient cardiovascular risk. You can use WHO ISH tool because it doesn't need any lab values. You don't need patient lipid profile to start statin and categorize their risk. All other risk tools need lipid profile. That means if you're OPD doctor, patient come with hypertension, a smoker, high blood pressure levels, without lipid profile, you can categorize, you can assess their risk, and you can straight away start statin therapy with the WHO ISH tool. Those every tool is available in online platform. Okay, I'll discuss some few clinical cases, then you will be more familiar with these tools. Okay. So this is WHO ISH chart. I think you might have seen this chart in your ward. So this is it has male and female. It has patient with diabetes and patient without diabetes. And here you have the age, and here you have the cholesterol levels. And if you don't have the cholesterol level, still you can use these charts. Chart with cholesterol and chart without cholesterol. Patient with diabetes and patient without diabetes, male and female. Okay, this is WHO. This is actually a very primary tool. I don't recommend to go with WHO ISH because it sometimes miss many patients with high risk. Okay. With this risk assessment, you can categorize patient low risk, moderate risk, and high risk. Low risk means less than 10. The green areas are low risk patient. Moderate risk is 10 to 20. It's a yellow region. And high risk is orange to above. Okay, this is WHO ISH chart. Okay. So what I recommend is to go ahead with this SCORE 2 or SCORE 2 OP. That's the European recommended risk assessment tool for assessing patient risk level. So it uses many variables: age, sex, smoking, blood pressure, non-HDL cholesterol. And it again categorizes patient into low, moderate, high, and very high risk. So you can use this scores calculator in online format. In MedCalc, you can see this calculator, and it only takes a few minutes to risk stratify the patient. You only need patient sex, age, smoking status, blood pressure, total cholesterol, HDL cholesterol, and the risk region. Usually our region, it considered as moderate risk region. With that, you can categorize the patient risk. Okay. I know it feels a bit confused at this point. So I'll explain in a real case scenario, then you will get used to this risk stratification thing. So basically, this summarizes the risk and the decided management. So if your patient risk is low risk, that means your risk calculated risk is less than 2. Usually you don't need statin, but your LDL target is 160. You should follow up the patient. If the patient risk is moderate risk, that means 2 to 10%. You should review the patient in 3 to 6 month time. And if your target of less than 100 is not achieved, you can start moderate intensity statin. If patient is high risk, that means more than you should tend to 20%. Statin is recommended, and our target is less than 70 plus 50% risk reduction. You need high intensity statin. And the patient is very high. That means if the score risk is more than 20%, statin is must, and your target LDL is less than 55 plus 50% reduction. So this with that. So this is what I meant by my risk assessment. So if you're having low risk, that means score or our risk gives less than 2%. You are having low risk of development of atherosclerotic disease, but your lipid target is less than 160. That means if your patient, we'll say 40-year-old patient come with the cholesterol of, we'll say 200 total cholesterol, and your risk is less than 2%, you should follow up this patient targeting cholesterol of less than 160. Next time, he at least 3 to 6 months, we should review the patient with lipid profile. If the target, that means if the cholesterol target is above 116, then we can consider starting statin. Okay. With the moderate risk, your target is less than 100. High risk categories, you should target a much lower range of LDL values. If patient is high risk, your target LDL is less than 70 plus 50% reduction. That means if your baseline LDL level is, we'll say 60, that's normal, but patient had a myocardial infarction. So we should target of lipid profile about 30. That means the patient LDL is baseline 60. We need to target of LDL is 30. That's like 50% reduction from the baseline. So I haven't seen a patient who's achieving that amount of our lipid target. That's the main reason for development of recurrent myocardial infarction, because we are not achieving our targets. Okay. And very high risk patients, the target is much lower, less than 55. And extreme risk means if myocardial infarction patient coming with recurrent attacks within 1 year, 2 attacks, they are at very extreme risk. In that case, our lipid target is even more lower. That's usually they should maintain LDL of 40 plus 50% reduction from the baseline. Those are the guideline recommended lipid targets. So my question is, have we achieving these targets in our population, our patients? So we'll discuss in coming slides as well. So once you made the decision to start statin, usually you start the statin. That's the first recommended drug of choice, and then you add ezetimibe, and then depending on the availability, you decide to add on therapy. Add-on therapy depends on the availability. Usually, third line drug is the PCSK9 inhibitors, but we don't have PCSK9 inhibitors here. Then you can try bempedoic acid, bile acid sequence, fibrates, and omega-3 fatty acids. Usually, statin ezetimibe is available in our setup. So I'll discuss a bit about statin and the ezetimibe therapy. So you all know statins HMG-CoA reductase inhibitors. So it reduce the hepatic cholesterol synthesis, which lead to upregulation LDL receptors at liver surface. So LDL uptake to liver will be increased. So LDL level will be reduced. But apart from this cholesterol reduction, statin has other beneficial effects. Like it has anti-inflammatory action, and it has plaque stabilization action, and it has antioxidant properties, and it acts as a better endothelial functions, and it has immunomodulatory actions as well. So starting statin is not only for reduction of cholesterol level, because it has many other good effects for better outcome. Okay, so sometimes we see patients who after MI who start on high dose statin, but subsequently statin dose is reduced and at some point it has been omitted because of cholesterol was normal. So that should not be done in our practice. Okay. And this statin classification, actually statin is classified not from the dose, it classified depending on intensity. That means high intensity, moderate intensity, and low intensity. High intensity means not about dose, it's about how much percentage LDL cholesterol reduction can be done with that statin. If you start atorvastatin 40, that lowers cholesterol about 50%. That's why it's high intensity statin. Rosuvastatin 20 to 40. That lowers cholesterol, LDL cholesterol about 50% from the baseline. And moderate intensity, it lowers LDL by 30%. Low intensity, it's less than 30%. Okay, that's why we are starting high dose statin in patient following MI or atherosclerosis cardiovascular disease. We need 50% reduction of the LDL cholesterol level. That's why you need to start high intensity statin. Okay, I think you all got the point. And the statin side effects, the common side effects are these muscle-related side effects, liver effects, and metabolic and endocrine effects. Actually, some say statin in primary prevention, it increased the development of diabetes. It's actually, there's a guy, some studies has shown that if you start statin early in younger generations, it carries a small amount of risk of developing diabetes in elderly age. That's actually true, but the thing is overall risk reduction is more than the actual risk of diabetes. And some say high dose statin increase the risk of stroke, ischemic stroke. There are some evidence, but even the risk of development of hemorrhagic stroke is very far more lower than the development of ischemic stroke without statin. And there are rare side effects as is neurological, gastrointestinal, hematological, and dermatology. Those are pretty rare. So in my research also, we actually did a research about statin dose and side effects. In our setup, usually we start at atorvastatin 40, but you can go to atorvastatin 80 milligram. That's the maximum dose. I only have seen patients with 60 milligrams of statin, but about 0.1 to 1% only I got many high side effects like rhabdomyolysis. Only one patient among 230 patients I studied. So these side effects are very rare. Okay. With that, I'll go to the next line of management, the ezetimibe. Actually, the ezetimibe is reduce the cholesterol absorption from the gut, and it reduces the cholesterol by 15 to 25%. And it's usually well tolerated. And keep in mind, ezetimibe should be given in or the morning as a morning dose, not as a night dose. Because ezetimibe reduces the cholesterol absorption. To reduce cholesterol absorption, you should take some diet to reduce the cholesterol absorption. So ezetimibe should be prescribed in the morning. Okay, and it doesn't need any renal dosage. And this newer therapy, the PCSK9 inhibitors, actually what it does is PCSK9, it binds to this LDL receptor, and it causes LDL receptor degradation in the liver. So LDL cholesterol uptake will be reduced. In PCSK9 inhibitors, it blocks this PCSK9 protein bind to this LDL receptor, and it maintains LDL receptor without metabolizing the lysosome. So the LDL cholesterol uptake will be increased and LDL clearance will be increased. That is the mechanism of action of this PCSK9 inhibitor. Actually, it has a 50 to 60% of LDL cholesterol reduction and very low side effects. Actually, sometimes in Colombo region we have this inclisiran. It usually given twice a yearly injection. Okay. We do have this PCS9 in private sector, but not in government sector yet. Then the other add-on therapy is the bempedoic acid, bilysequin, fenofibrate, and omega-3 fatty acids. Okay, bempedoic acids actually I don't think the availability of bempedoic acid nowadays. In bile acid sequestration, we do have. Fenofibrate is mainly for the hypertriglyceridemia. I'll come to that part later. And this omega-3 fatty or the fish oils. Even we do prescribe this fish oil, it has minimum effect of LDL reduction. It's actually less than 10%. Okay. These are the add-on therapies. So this is the important side. The moderate intensity statin about 30% reduction, high intensity statin 50% reduction. Ezetimibe 20. If you combine this high intensity statin to ezetimibe, you can reduce cholesterol by 60%. If you combine this high intensity statin to ezetimibe to PCSK9 inhibitors, you can almost 80% you can reduce. That means if your LDL cholesterol is 100, if you combine these three drugs, you can bring it down to 20. Okay. So I think that this the drug aspects, I think if you have any question, you can ask for me. Usually we typically calculate this calculation. Is there any rough guidelines? Yeah. Any cutoff values for initiation of statin? Yeah. Basically, during the ward round, if patient ever had any myocardial infarction, no doubt you can start high dose statin. And second thing, if patient is diabetic, age more than 40, you don't have to do any risk calculation. You can straight away start statin. And third thing, if the patient is CKD, stage 3 to 5, you can straight away start statin. Third thing, if you have ever done LDL cholesterol and LDL more than 190, you can straight away start statin. You don't need any risk calculation. Another thing, if the patient is having diabetic, whatever the age, with additional cardiovascular risk, that means if patient having microalbuminuria, neuropathy, nephropathy, that kind of situation, even age doesn't matter, you can start statin. Those are typical patients that you should start on statin. You don't need any risk assessment. But in other patients who have hypertension, smoking, that kind of situation, usually the threshold of starting statin is much low. You can start statin, but the thing is, you don't know your targets and the dose of any statin. In that case, if you can stratify from the beginning, it's better for the follow-up. Okay. Actually, this online calculation won't take that much of time and show how the calculation has been going to be done. Okay. Then about little bit about the follow-up. This follow-up also important. We starting statin, but we don't have proper follow-up. Once you start in statin therapy, lipid profile should be repeated at least 4 to 12 weeks time. That means after 3 months, lipid profile should be repeated. And then every 3 to 12 months. That means then you can repeat lipid profile annually, depending on the risk and the control. And this other blood workup, you should do your liver profile, the AST/ALT, as a baseline, and then after 3 months of therapy, then after 1 year, then you don't have to do the liver enzyme assessment. And CPK is not routinely recommended. So basically, if you start patient with statin, better to repeat lipid profile in 3 months time to see whether patient has achieved the lipid targets. And then liver enzyme you should do at baseline, and then after 3 months of therapy, and after 1 year, then you don't have to do liver, because statin can cause liver injury. That's why we are monitoring the liver profile. And then you don't have to do the CPK as a regular method, because it's very rarely statin cause muscle damage. Okay. We learn at least the upper limit of 3 times the upper limit. Is still there the elevation of stop statin? Usually, the statin-induced liver injury is if the AST/ALT elevation less than 3 times from the upper limit of normal, you can reduce the load with monitoring. But if the liver is, you don't have to stop it. But if more than 3 times of a limit, you should stop statin and give 1 or 2 weeks of statin period. Then you can re-challenge with a lower dose. That's the guideline recommended. 3 months after starting statin. Yeah. So then about the secondary targets, that means if once you assess your patient risk, and then you start your statin, and then you follow up, we'll say patient achieved our targeted LDL values. So if the initial LDL is 100, now he has achieved the LDL of 50 after 3 months of therapy. Do you have any other secondary goals after this achievement of initial LDL targets? Yes, we do have. That means even you start statin targeting LDL reduction, once you achieve that target, you can still uh, target the non-HDL cholesterol reduction. That means the other rest of the cholesterol. Once you achieve your LDL target, you can calculate non-HDL cholesterol levels. That means total cholesterol minus HDL cholesterol. Then you will get your non-HDL cholesterol levels. Then the non-HDL cholesterol target is usually 30 milligram per deciliter higher than. That means if your LDL target is 55, then your non-HDL target is 85. Once you achieve your 55 of LDL target, you can reassess the patient with non-HDL target. Then you can decide on increasement of the statin. Basically, what they say is they favor the high dose statin rather than statin dose reduction. Usually, what we do is once we achieve the LDL target, we reduce the statin dose. That's not the correct way to assess the response or the target achievement. You should calculate non-HDL cholesterol. If the non-HDL cholesterol is higher from the target non-HDL cholesterol levels, you can increase your statin dose. Okay, we'll keep the secondary targets aside. We'll try to achieve at least the primary target. Okay, then the clinical scenarios. You see, okay. So this is the case one. So 65-year-old patient with following MI, he has done this lipid profile and shows total cholesterol of 210, LDL of 80, and triglyceride of 190. So what is the management apart from antiplatelets? What are you going to do for this patient? Are you going to start studying on this patient? Okay, good. So what is the dose of statin in this patient or the intensity of statin? Yeah, it is high intensity statin. You don't need to do any risk assessment for this patient because patient already had MI. So patient having high risk of cardiovascular disease, patient need high intensity statin. So here our target is LDL of less than 55 and 50% reduction from the baseline. That means his LDL is 80. We should target LDL of 55 at 3-month follow-up and 40. Okay, that means the 50% reduction from the baseline. So that is the common case that we could get in our medical boards. Yeah. Guideline recommend at least we should target that lipid reduction from during initial 3 months of time. In 3 months, soon as possible. But usually it doesn't happen now. Then at least 6 months of time, if we can achieve the target, that's better. That means even 3 months time, if the target is not achieved, you don't wait for another 3 months. You can add the second line agent, basically. Then you can review the patient in 6 months time. If the target is, then you can decide on reduction or continuation of therapy. Okay. Yeah. I'll come to that part as well. But the thing is, for short answer, rosuvastatin basically is a water soluble molecule, and atorvastatin is a lipid soluble one. One thing is the rosuvastatin, the potency is a bit higher than atorvastatin. That's why you need a small dose. But the thing is, I haven't found any trials which compare these two statin head to head. You can start whatever you like, depending on the availability and the cost factor. Keep in mind, if you start rosuvastatin, that you can't. The maximum dose is rosuvastatin 20. It's a high intensity dose. You can't start rosuvastatin 20 in CKD patient. Maximum allowed dose is 10 milligram in CKD patient. That's the limitation with regard to rosuvastatin. But atorvastatin is a liver metabolized drug. You can increase to 40% even in CKD patient. Okay. There's no straight away answer. That's depend on patient clinical decision. Yeah. Okay. Then we go to case 2. So this 55-year-old male with hypertension He came with following lipid profile. His blood pressure is 140 by 90. He's a smoker. His lipid profile, total cholesterol 240, LDL 90, triglycerides 85, and HDL 40. LDL actually is 90, the cutoff is less than 100. So what's your management for this patient? Are you going to start statin? If you're going to start with high intensity, low intensity, and what's your LDL target? So this is the other kind of common cases that we get to our clinics. Okay. And by the way, I want to emphasize that when you are doing lipid profile, there's no such things called reference ranges. You can't get reference ranges in lipid profile. The reference ranges depend on patient risk factor. That means if your patient is MI, your reference range is less than 55. It's not the usual reference range. Okay, when you are looking at the lipid profile, don't look at the reference ranges. Reference ranges doesn't matter. It's our target LDL cholesterol. Okay, now coming back to this case, what do you think? This kind of case is a bit tricky. What to start, how much to start, what's our target? This is the case that you need the risk assessment. Okay. So if you assess this patient risk, he's a male, age 55, he's a current smoker, systolic blood pressure 140, total cholesterol 240, HDL cholesterol 40, and our risk region is moderate. He's having 11.7% risk of 10-year cardiovascular disease. 11.7 means high risk. Okay. So high risk patients definitely they need statin. Ideally, they need high intensity statin. So ideal situation, this patient need high intensity statin even his LDL is normal. With regard to LDL, report says less than 100, that's a normal range, but once you assess his risk, he's at higher risk of developing MI. What usually happens is we ask the patient to do the lifestyle modification, come in 3 months time. He won't come in 3 months time, he come in next month with MI. That's a common scenario. So I think we should actually look into that factor. Okay. Because I want to highlight this, even though here your cholesterol, LDL is cholesterol normal, his non-HDL cholesterol is high. Okay. LDL cholesterol normal, but his non-HDL cholesterol, that means 245, basically 200 is high. That's why our risk score gave us a higher risk of MI. Okay. And then the case tree. Okay. Do you have any questions so far? Then you can ask me. Okay, the case tree. Again, a 45-year-old male coming with following lipid profile done during routine medical checkup. He's a non-smoker, blood pressure normal, total cholesterol 230, LDL 180, HDL 45, triglycerides 100. So what is your management plan for this patient? This patient previously no medical history. He has done some medical checkup and his lipid profile shows some elevations in lipids. So what is your management plan for this patient? Do you think he needs statin? Okay. To assess that objectively, then we go for risk stratification. He's a male, age 45. He's not a smoker. Blood pressure 120, total cholesterol 230, LDL 45. Our risk region is moderate. So he's having 2.8% of risk for the development of cardiovascular disease. That means he's categorized into moderate risk. Okay, he's in the moderate risk category. So you should review this patient in 3 to 6 month time with repeat lipid profile, and meanwhile ask him to do lifestyle modification. If you come 3 months time with lipid profile and LDL cholesterol more than 100, so our target of less than 100 is not achieved. So you should start this patient on statin. That's how this risk stratification, LDL targets, and the management should be done with regard to management of this lipid. Okay. Patient was like, but patient is not reliable. Any lifestyle, he might not come to the follow-up. Yeah, that's actually a clinical decision. And this is actually standard, I mean, the ideal situation. If you think the patient is very obese and even though he's saying he's not smoker, he's having zero obesity. Yeah. Yeah, that's the limitation with regard to this risk calculation. Actually, here we are not talking about his other comorbids and the family history and I mean, the apolipoprotein A assessment. These things not included in this calculation. So you can miss some patients, but if at least you can catch few patients. If you're not using any calculator, most of the time you will miss many patients. So if you think this patient will not come to your clinic again and his lifestyle modification is doubtful, then you can straight away start moderate intensity study. But what usually happens is when you start in moderate, we say we start at Austin 40. He'll do a lipid profile in 3 months time. Lipid comes as normal. Then he'll stop the therapy. He thinks the lipid, the high cholesterol is cured. That's what happens most of the time. Yeah. Yeah. So if the patient achieved his target of LDL of less than 100, then we can follow up the patient. Like in 6 months time, if they still maintain, then you can decide on reduction of the statin therapy. But to stop statin, usually guideline not recommended. Usually there's no grade 1, I mean, recommendation to stop statin. When to stop statin? They favors continuation of statin because statin has other benefits, which I described earlier, the endothelial dysfunction, immunomodulation, that kind of stuff. So you can still monitor patient while dose reduction, but usually they don't recommend to stop statin. I have seen some prescribing every other day statins, but the problem is the BNF, the recommendation is to once daily regime. So I don't know any trial evidence for that, but you can try it if patient not taking statin regularly. But before that, I think it's better to find out why he's not taking statin. What is the reason? Most of the time, they are having this symptoms called SAMS, statin associated muscle symptoms. But usually they will disappear with time. Okay. Very rarely they will develop myositis. Okay. Usually it's better to find out why he's not taking statin. If you, is it because of the side effects or is it because of his misconception regarding statin? Better to address that first and then decide on the dosing. Usually once every other day dosing regime, there's no guideline recommendation for statin. It's a daily regime. Okay. So that covers the core of the lecture. So hereafter I will discuss the few special circumstances. Okay, so far what we have done is we talk about the basic physiology of statin, then when to start statin, the few patient categories which you don't need any risk stratification, you can straight away start, and when to assess the patient risk, and how to start statin, and what is your LDL target. Okay, don't worry, I will share the lecture in the group, then you can freely go through the slides. Okay. This is what you also have asked from me, the management of dyslipidemia in young. Actually, it's both diagnostic and management challenge because young generations, usually the dyslipidemia most of the time due to primary lipid disorders. That comes from their genetic issues. So, and the other problem is in younger generation, if a young 25-year-old patient come with high lipid profile, we don't have any risk calculator to risk stratify those patients. Okay, WHO scope, all the risk calculators are for age more than 40 years of age. Below 40 of age, we don't have any data. So management of dyslipidemia in younger population is mainly the clinical decision. If patient is LDL 190, then you can straight away start. But if the LDL less than 190, then your clinical decision comes into place. If the patient is having hypertension, smoking, obesity, those other risk factors, and the family history, with that you can decide on statin therapy. Okay. Nowadays, many patients come, young age patients come with a lipid profile of elevated lipid profile. That's how we should manage that kind of patient. Okay. And then even if they age less than 40 and if they had a MI or stroke, whatever, atherosclerosis cardiovascular disease, then you don't have to stratify. Straight away you can start high dose statin, targeting LDL of less than 55 and 50% reduction from the waist. This is the newest guideline, the American College of Cardiology. They now promoting the screen early. Actually, they promote the repeat profile at 2 years of age if the family history is there, and checked regularly, and again at the age of 90, and again your middle adulthood and the elderly age. So now they're promoting assessing risk cholesterol in very young age. Okay. And then the management of dyslipidemia pregnancy, I think this again important factor, because in pregnancy you will get high cholesterol levels anyway because of the physiological changes. You will have high cholesterol levels, high triglycerides levels, and these changes are actually normal. Usually they will resolve in the postpartum period. Usually pregnant patient doesn't need any management unless they have a significant cardiovascular disease. If the patient had any history of myocardial infarction, in that case you might think of continuation of some lipid lowering therapy, not the statin. But otherwise, usually they don't need lipid lowering agent during the pregnancy, because we don't have many robust evidence about the pregnancy lipid disorder management. But the ESC recommended only the bile acid sequence, that your cholestyramine in the pregnancy to reduce the lipids, not the statin. The statin is contraindicated in pregnancy. I think you almost should know that part. And postpartum period, usually we should check the statins, cholesterol, usually 6 to 12 weeks time. Usually they will settle by its own, but if the lipid cholesterol is high, then you can decide on statin therapy. But keep in mind, you can't start statins during breastfeeding. But after, if your mother is not breastfeeding, in that case, you can start statin. And important thing, if a young patient comes with high lipid levels, especially a female, think twice before starting statin. Why? Statin is contraindicated in pregnancy. If we'll say young female is on statin and she is expecting a pregnancy, you should stop statin at least 3 months prior to your conception. Okay, otherwise it will cause teratogenesis. Okay, that's again an important factor. And this cirrhosis and statin, usually many of us bit reluctant to continue statin in cirrhotic patients. We think statin will cause no liver damage. So basically, I'll rush through these slides. If the patient having compensated cirrhosis, statins are safe. But if patient having decompensated cirrhosis, that means patient with ascites, hepatic encephalopathy, upper GI bleeding, in that case, still you can continue statin with regular monitoring. What they recommended is to go for the pravastatin, which has minimal hepatic metabolism, rather than the atorvastatin or rosuvastatin. Okay, and the CKD, usually, this is what I told you earlier. If the patient having CKD stage 3 to 5, they should be on statin. CKD 3 to 5 non-hemodialysis patients, they should be on moderate intensity. This is from PD guidelines. If you are starting atorvastatin, you can continue 20 to 40, but rosuvastatin not beyond 10. And CKD patient on dialysis, you don't start statin as a newer therapy. If they are already on statin, you can continue. Okay. And this other common effect is hypertriglyceridemia. Sometimes patient will come with high triglycerides levels. The risk of hypertriglyceridemia is it can again cause myocardial infarction, the atherosclerosis cardiovascular disease, as well as it increase the risk of getting pancreatitis if the triglyceride level is more than 500. When you treating patient with hypertriglyceridemia, it's better to think about the secondary causes before starting your treatment. That's your familial hypertriglyceridemia, endocrine disorders like hypothyroidism, diet, and especially the alcohol. And sometimes drug also can cause hypertriglyceridemia, the beta blockers, thiazide, and steroids. Hypertriglyceridemia management is again the first line management is statin. You don't start fenofibrate straight away for the hypertriglyceridemia patient. You start with the statin. The statin the first line. Then you can add fenofibrates if the triglycerides are very high, more than 500. Then there are other therapies like omega-3 fatty acids and vitamin B3. Omega-3 fatty acids means the fish oils. Okay, this is about the hypertriglyceridemia management. And then lastly, last slide, the primary lipid disorders, because sometimes genetic conditions can also cause high lipid levels. And again, high lipid levels can cause MI and stroke risk. So this is an actual patient we got during my previous hospitals. This patient came with triglyceride total cholesterol of 464, triglyceride 133, HDL 48, this non-HDL 416. See the LDL cholesterol. LDL is 393. If you get this kind of very abnormal reports in young patient, always think about primary lipid disorders. Basically, familial hypercholesterolemia, familial triglyceridemia, they are genetic causes for them. And they do have some clinical clinical signs. Chromoxanthoma, distivorous xanthoma, eruptive xanthoma. Actually, that patient had this tendon xanthoma in his Achilles tendon. So that was actually a primary lipid disorder. Anyway, management is the same. It's again initiated from statin. So lastly, take-home message. It's not just about the numbers. It's about the assessment of cardiovascular risk and treat to targets to achieve the to reduce the risk and achieve the target. Lifestyle modifications should be the first line, and always consider secondary cause. If the patient having high triglyceride levels, at least 2 TSH levels, so with the patient having hypothyroidism. If you treat the hypothyroidism, anyway the lipid level will be normalized. And don't delay the treatment, because usually we do have clinical inertia of starting lipid therapy in younger population. But if the risk is high, don't wait to start the statin. At the end, it's easier to prevent than to treat. And thank you. And I would like to answer any question.